and it's going to be only for 1 hour too. So you are not going to go beyond 8 o'clock. I hope so. So you're going to be very fast. Just going to be one small aspect of a lot of the things that we have to learn. So we're still on the conditions and diseases that can affect the penis. And here we are with what we call ulcers on the penis, the ulcers. And it will normally be under genital ulcers. Now, the genitals, of course, will include the vagina, the penis, the perineal areas. They all belong to the genital area, so to speak. And since we are specifically dealing with andrology, and for that matter, specifically dealing with the male reproductive system, then our concentration will be on the penis. So now we're going to move from genital ulcers to penile ulcers. I hope you can understand. I appreciate that. Instead of saying genital ulcers, if you're talking about genital ulcers, you have to talk about the ulcers in the vagina, ulcers in the vulva, ulcers in the perineal area, and so forth and so on. But we want to scale down to our subject area of andrology, and therefore it's going to be just the penis. So penis can have ulcers, and classically we have three types of diseases or conditions that can create the ulcer. So if you see an ulcer on the penis, it's due to either syphilis, due to chancroid, due to genital herpes. And all of these have different etiologic agents. And of course, you will see that even though they are all ulcers, you can look at it critically and then can make a determination whether they are syphilitic or chancroid or the herpes. Right. So today we're going to look at syphilis alone. And we're not going to look at syphilis in its entirety because that is also a whole topic altogether. But we're going to look at that aspect of syphilis that can create an ulcer on the penis. All right. So we are not going to tackle syphilis as a broad topic on its own. We're going to look at the aspect of syphilis that creates an ulcer, which we call syphilitic ulcers. All right. And then we move to the others. So for today, because of our time limitations, we're going to just concentrate on syphilis. And like I've said, it's not even syphilis as a whole. It's going to be just the aspect of syphilis that creates an ulcer. So, of course, generally, you know that syphilis, of course, is a genital ulcer disease that is caused by a spirochete. And you know, for the bacteria, you have the group of bacteria that are called spirochetes. And I'm sure you have a rough idea about their morphologies. A typical spirochete named the treponema. So we have the Treponema pallidum. It also have a lot of subspecies. So for example, we have the Treponema pallidum subspecies pallidum. And then you have the Treponema pallidum subspecies endemicum. We have the subspecies also called caritum, and then also the petini. All these cause variety of diseases. But the one which can affect the penis is our subject area. But you have to get the idea because the other species, of course, they can also create or cause antibodies to be formed. And when you come to the area of syphilis serology, where we are going to look at the antibodies that is going to be used as your diagnostic tool, then you should also appreciate the fact that other species or other subspecies of the pallidum could also create antibodies that could also mimic the one for our subject area, the syphilis. That's why I've thrown in this area, this small bullet of the other species. So Treponema pallidum subspecies petini causes a common disease called yaws. These days, you don't seem to get too much yours, but they are still there, especially in some of our remote areas. We also have the endemicum, the subspecies endemicum, which causes endemic syphilis, or disease called Begel. This part common in the Middle East area. And then Palladium caritum causes a disease called Pinta. That's also common in South Africa. So for our area, it is typically either T. pallidum, which is a syphilis, or T. pallidum subspecies petin, which causes the yaws. All right. So that's just by way of introduction. So it is also important to know that syphilis is a multi-stage disease. When you say multi-stage, it means that it has stages. You can have stage 1, stage 2, stage 3, and so forth and so on. So syphilis, by way of introduction, we say it is a multi-stage disease. And what are the stages? The stages comprise of what we call primary stage, secondary stage, latent stage, and the tertiary stage. And each of these stages, primary, secondary, they all have their variety of clinical manifestations. Now, like I said, we are not going to tackle syphilis in entirety. We are going to look at syphilis, which aspects of the stages that can affect the penis. And of course, that can create an ulcer. And so as we move along, you see that our concentration is going to be only on the primary syphilis, because it's only at that stage where you can create, or which can create an ulcer on the penis. All right. So we're going to look at the primary stage of syphilis. So I'm sure you know that it's a sexually transmitted disease. So once you have a contact and the other person appears to be infected, then of course it will take an incubation period. All right, it will take between 10 to 90 days for manifestation of the primary lesion. All right. So, and this stage, which we call the primary stage, is characterized by a single, usually single, but it could be multiple, especially if the patient is already immunocompromised. If the patient is an HIV patient or immunocompromised, then it could be multiple lesions instead of a single lesion. So don't think that when somebody have multiple lesions or ulcers on the penis, it cannot be an ulcer. That should rather give you a suspicion that the patient, you are considering the patient for syphilis, but you also have an HIV, because it's only in the immunocompromised patients where you can have multiple ulcers as a manifestation of syphilis. Right. So, and they are usually painless. I mean, they feel no pain, and non-suppurative. When it says suppurative, it means that they produce a lot of pus. All right. But when it's non-suppurative, it means that doesn't even produce pus. So it is painless, non-suppurative lesion, and it's usually called a chancre. And this chancre or the ulcer will normally be found at the site of the inoculation. All right. It is also called hard chancre. So we have the hard in inverted commas. Hard chancre because it's hard. So that even if you touch it, the patient will not feel any pain, and it looks very, very hard, even though it's a sore. It looks very hard. So sometimes you can have it as hard chancre. It's important to know this because when you go to the next ulcer, which you call a chancroid, it is typically coming from a chancre. I know that the other day I was talking about some medical conditions and medical terminologies, and you see that certain terminologies, when you understand the suffix, all right, when you understand the suffix, it will give you an idea about the meaning of that terminology. So OID as a suffix, OID as a suffix means likeness or like. All right, so for example, if you have amoeba and amoeboid, you see that it is ending OID, so it is like an amoeba. So you are going to look at the other disease called chancroid. You see that it is just the chancre, which now you have an OID added. So if you have OID added to the chancre, it becomes chancroid. So what it means is that that disease, which we're going to talk about later on, is like a chancre. All right, it's like a chancre. And what is a chancre? A chancre is that ulcer which is associated with the primary syphilis. The difference is that in that ulcer, it looks soft. The chancre we're talking about, the other one is soft. So sometimes people call it soft chancre. All right. That's why it is important to differentiate between hard chancre and then soft chancre. When you're dealing with the soft chancre, they rather talking about chancroid, and that is also caused by different etiologic agent altogether. So I just want to establish the fact that it is okay to say just chancre. But sometimes if you read elsewhere, you see hard chancre. What it means is that you're talking about this chancre, which is associated with syphilis, which looks very hard. All right. So we move on. So you have a typical picture of chancre. Look at this one. Yeah, this one, like I said, it is double. You have this ulcer here, this ulcer here. So for this patient, you may be checking for syphilis, but it will still be very, very important to check this patient for HIV because it is unusual to have multiple ulcers. All right. If you have multiple ulcers, for which all of them look like syphilitic, then that same patient could also risk having HIV. All right. So that is what it is. All right. Now, with the still on the primary stage of syphilis, I mean, without treatment, the lesion spontaneously disappears. That's a fact. Even without treatment, the lesion, the ulcer will disappear. And almost always without scar formation. You see that is unusual because for most ulcers, if an ulcer heals, you see a scar. But in this particular case, even though you didn't treat it, you didn't take any medication, the ulcer has disappeared, yet there is no scar to its trail. So, and that's where probably a lot of people will even have the infection without knowing it. All right. So, it is important to take note of that. The non-spontaneous regression of the lesion, what this is saying that it's a known fact that the lesion will spontaneously or automatically regress. When we talk about regression, it means going back. All right. So it means that the lesion will go back. When the lesion is going back, what it means? What it means that it's healing. So it means, and it's a known phenomenon. But the disappearance of the lesion or of the chancre does not signal an end to the infection. Very, very, very important. You know that you can have a syphilitic ulcer, and you know that if you treat it, yes, the wound will go, and normally treated with penicillin. Up to date, syphilis, and for that matter, treponema pallidum is still susceptible to penicillin. All right. I'm not saying go and treat it, but what I'm saying is that it is easy to treat syphilis, and from time immemorial, it is penicillin that has been able to take care of or to cure syphilis, and up to date, it is still penicillin that is being used, essentially, unless the patient probably reacts strongly to penicillin, where other doxycyclines and so forth could also be used. But it is very easy to treat early syphilis, which is the primary stage. But what we are saying is that, so if you treat it, then it means the wound, the ulcer will go automatically. All right, and then to go, and then it's like that's the end of it. But if you don't treat it, like you said, the wound, or for that matter, the ulcer will go automatically. Now, if you treat it, then to go, then it's like that will be the end of the disease condition. But if you don't treat it and then it goes away, then it's rather moving into another stage. All right, it's moving into the blood. Right now, at this stage, it is purely a skin condition. All right. So the treponemics gain access to the bloodstream in untreated primary syphilitic patients. This is what I explained earlier, that when you treat it, of course, then the disease is gone, you're also free. If you don't treat it, the lesion is gone, but the infection doesn't end there, it will go into the bloodstream. I'm intentionally bringing this aspect because this should be the end of the primary stage. And I'm saying that we need to appreciate the fact that we're dealing with penile ulcers. Penile ulcers, it is only the primary stage of the syphilis that will give you the ulcer. The next stage, you see that the ulcer is gone. And so there's no need for us to spend time on the other stages. But I'm bringing in the concept of what we call spirochetemia. Spirochetemia is spirochetes in the blood, like when you can have parasitemia, all right, or septicemia. And you appreciate the fact that I've said that most of the medical terminologies, I mean, if you can understand some of the suffix and some prefixes, it's very easy. So you have amia here, and amia means blood, okay? And then you have the spirochete. So spirochete in the blood becomes spirochetemia. So I've just wanted to refresh your mind on some of these things. Otherwise, you have no business going into the next stage where the ulcer has disappeared. I just want you to know that after the ulcer has disappeared, it goes into the bloodstream. And the presence of it in the bloodstream now initiates the next stage, which you call the secondary syphilis. And I'm saying again that we are not going to go into the secondary, the latent, and then the distant. Otherwise, you'll go off. All right. You want to stay focused with the genital ulcers. All right. Now, so as lab scientists, our big area is with the diagnosis. And take note of this area. And today's lecture is going to be very, very brief. I don't want us to go beyond the 8 o'clock. And I also don't want us to take things too much in order at the end of the day we don't understand. These things are very, very, very important, even though it's andrology. It is still an element of microbiology, and it is still causes a lot of misdiagnosis and misinterpretations in most of our laboratories across the country. So take this aspect very, very seriously so that you can make the necessary corrections in your labs as it may be the case. So still within the space of primary syphilis, and here you have a wound or a lesion, how do you make a diagnosis? The important thing is that lesions of primary syphilis typically contain large numbers of the spirochetes. So you have a lesion, there's an ulcer on the penis. The wound or the lesion contain large numbers of the causative agent, which is the T pallidum. That's why if you have an ulcer on the penis and you make any penetration anywhere, you infect the other person. It could be if you have anal sex, then the person is going to have it. So you could have the ulcer appearing in the anus, even though it's supposed to be a genital ulcer, but you can have it if you do oral sex and you know that you have an ulcer on the penis. Of course, the patient is going to is going to have an ulcer in the mouth. As simple as that. All right. So it is important to note some of these things so that you can use them in your counseling, you can use them in your advice to even your other colleagues. So we are saying here that the lesions, the primary syphilis, the lesions, they have a lot of asparagines, and because of that, they are highly infectious. All right. Now, so just a little information about the bacteria. The bacteria is elongated. So it is between 5 to 15 microns, but it is very thin. All right. So you have the length and then the width. The width is just about, in fact, less than 2 microns. But just about, the largest one would be just about 2 microns, but they are usually less than 2 microns. And because they are less than 2 microns, you know what we call, in microscopy, you have what we call the resolving power of the microscope. The resolving power is the capacity of the microscope to differentiate two things as two, all right, or to be able to see an object, all right, and see it as distinct. That's the resolving power. The resolving power of the normal microscope is 2 microns. Okay, so if you have an organism which is less than 2 microns, that means that the microscope will have a challenge in seeing it. So that's why ordinary, so we say it is submicroscopic. That is below the capacity of the microscope to identify it or to see it. So you see that the treponins, and for that matter, spirochetes, you cannot see them under the microscope because they become submicroscopic. When it says sub, below the resolving capacity of the microscope. I hope that, yes, they are long. They are long beyond the resolving power, 5 to 15. Yes, that's long enough. But the width is below the resolving capacity of the microscope. So in effect, in effect, the microscope will not be able to detect it. So one, you are seeing that it cannot be seen under the microscope, and it cannot be gram stained. After, if you gram stain it, and what microscope are you going to use? You are going to use the biofilm microscope, but you cannot see the organism by way of the fact that it is submicroscopic. So there's no need gram staining it. So you cannot gram stain it, and it's also not questionable. So these are the things. So look, we are going to look at the diagnosis of primary syphilis. And we are seeing that the lesion, which is a manifestation of the disease, has a lot of organisms. So if it has a lot of organisms, then it will be proper to just take specimen from the lesion or the ulcer, and then do gram stain and then look at it. But even if you do gram stain, gram will not pick it because the microscope you are going to use cannot see it. So gram is irrelevant. This organism has also not been cultured on artificial media. So we say it is non-culturable. Even though the organisms can be inoculated into rabbits and be kept there. So you can in the laboratory, we have some laboratory animals. Yes, these are where organisms like the treponins can be stored. So they can be inoculated into the organism, and then it's like the organism is harboring it. Anytime you need it, you can take some. The organism can be so the organism can be harvested from the rabbits, so to speak. But for normal laboratory cultures, it is not. So you can't gram stain it, and then you can't culture it. So how do you now make the diagnosis? Let's move forward. So the definitive diagnosis is based on direct demonstration of the motor treponins in the material from the chancre or the lesion exudate in dark field microscopy examination. It's very, very simple. No, we have dark field microscopy. Unfortunately, most of our laboratories don't have dark field microscopes. We don't have it. So what it means is that when you have primary syphilis, it will be difficult for you to diagnose it from the lab. All right, it will be difficult because, like we said earlier, you cannot gram stain it, you cannot culture it. You have to do dark field microscope. Meanwhile, you don't have a dark field microscope. So it means that you end there. You can only use your experience, or the clinician can use the experience of how, let's say, a chancre looks like. Because the fact that you have an ulcer on the penis doesn't say that it's syphilis. Remember, we said that it could be syphilis, it could be chancre, it can be hepatic ulcer. All right. So the presence of ulcer doesn't say that you have a syphilis. Meanwhile, you can't gram stain it, you can't culture it. You also have a dark field microscope. So that's where you end. So unfortunately. All right. So, but in the event that you have a dark field microscope, then let's look at the procedure. So the surface of the lesion is cleaned with saline. All right. You know that the whole thing is painless. It's painless. So just cleaning the surface with saline, I mean, that's okay. And then it's gently abraded with dry sterile gauze. I hope it is something that can easily be done. So you wash it with saline, and then you use a dry gauze to just try to scrape. Of course, since it is not a blade or something, you can't say you are scraping. You say you are abrading it. Abrade. So you are abrading it with a dry cotton gauze, and then you get some material from there. That material that you get, you try to place on a slide. All right. And then, of course, you can just add just a little saline so that you make a preparation. And of course, in that case, you apply a cover slip. That's all. And then you examine it under the dark field microscope. Here, you are going to see, and you know that these are motile. You're going to see the motility, the motile spiral-shaped organisms. And that confirms the infection. So the abraded material, you are seeing serous transudates. You see the thing, a transudate is also like a fluid. It's a fluid, serous fluid. So we know that the lesion is hard. So sometimes the edge, you can squeeze the edge to get some fluid from it. The edge, even when you squeeze it, the patient will not feel any pain because the whole thing is painless. All right. So either when you squeeze the fluid that comes from it, that's the serous transudate, or you can abrade. That's why we say the abraded material or the serous transudate, in any of them. So if you have a serous transudate, then you may not need to add saline because it's all already in a liquid form. But if you abrade a material from the lesion, that's why you may have to add a little saline to it. But if it is just a serous transudate, which can be squeezed from the edge of the lesion, then you may not need, unless it is thick, unless the fluid that's coming from it is thick, then you may add a little saline just to make it more fluid. All right. Then apply a cover slip. The smear preparation is microscopically examined using dark field microscope. All right. It should be examined immediately after collection. Why? Because we are going to observe the treponins per their motility. So if you allow it to dry before we now go and examine, you won't see anything. So the preparation should be examined as quickly as possible because you are going to make a determination based on the mobility or motility. All right. So you don't have to waste time if you have the benefit of a dark field microscope. So dark field microscopy examination allows the definitive diagnosis of primary syphilis before the production of antibodies. Here we are saying that if you do the dark field microscope and organisms are there, then it's not like a presumptive something. It is indeed the definitive diagnosis. So dark field microscopy, if you are seeing motile organisms in it, it is definitive. I mean, there's nothing like, or it is probably, no, it is definitive. So the most definitive diagnosis of primary syphilis is by dark field microscopy. That's very, very, very important. Very, very important. All right. Now, at this stage, serology becomes almost impossible. Remember that serology, you are looking at antibodies. Antibodies production will take time. All right. Whenever you have a lesion or whenever you have an organism inoculated into you, it will take time for antibodies to produce. This is basic anybody knows. So you see that whenever there is a lesion, that's the first indication that the person has primary syphilis. At that point, if you go and do any serology, I mean any syphilis, using serum to do any syphilis test, it will show negative. And these are the things as lab scientists you should take note, because if you don't know some of these things, some clinician will know, oh, this is a classical case of syphilis. Go and do your VDRL. You go and do VDRL, it says negative. All right, then there's Wahala. So, this is a classical syphilis. Go and do the lab test. They say the lab says it's negative. Oh, then they make all sort of noise about it. But you know that the VDRL, which we're going to talk about very soon, is based on the antibodies which have been produced by virtue of the inoculation of the organisms. The body will take time to produce the antibodies. All right. And by that time, there's the wound or the ulcer is still there. Yes. If you were able to do the dark field microscopy, that would be fantastic, because the ulcer has numerous quantities of the causative organisms, which are the treponins, which you could have identified under the microscope. But you don't have a dark field microscope. You can't do a gram stain. You can't do a culture. And so you're almost powerless. So the primary stage, if you go and do syphilis, it may show negative. I'm saying may. I won't say not. It will show negative. I would say it may. The reason is that this is a duration. You say it is between 3 to 6 weeks. All right. So in the early stages, you see in the primary stage, the early stages, you still have no antibodies produced. But as you're getting to, let's say, we say 3 to 6 weeks. So by the time you get to the, let's say, the 4th, 5th, 6th week, the wound is still there. At that time, the body has started producing antibodies. So you can still get antibodies produced at the latter stages of the primary infection. Please take note. The antibodies can be produced at the latter stages of the primary lesion or the primary syphilis. But the early weeks or the early days of the primary lesion, antibodies will not have been produced. And therefore, if you go and do any serological test to show negative. I hope I've made my point clear. Right. Good. So let's look at what we call syphilis serology. Antibodies production within the in the condition of syphilis. So it's a syphilis serology. This is also going to be brief because, like I've said over and over again, we are not doing syphilis as an entire topic. We're only looking at the primary stage, because that's where you get your penile ulcers. All right. But we are saying that even when you have the penile ulcer, at the latter stage of it, where the wound is still there, the body will have started producing antibodies. So it means that Serology has a role to play even in diagnosing the primary syphilis, but that is only at the latter stages. All right, that's only at the latter stages. Now, once the body has been exposed to the organism, the body produces two types of antibodies. Now, the two types of antibodies are called, the one is called specific, the other is called non-specific. It's not about IgM, IgG, no. In both scenarios, we can talk about that, but we have this type of antibodies. One is specific, one is non-specific. What is the specific one? The specific one is the one which is targeted against the Treponema pallidum itself. You see, one thing about antibodies is about their specificity. The antibody will attack the antigen which stimulated its production. This one is basic immunology. You know this already. So if you have an antibody that is attacking other things which did not stimulate its production, then that's a different thing altogether. But technically, antibodies will target the antigens that cause their production. So that is about the specificity of antibodies. So you are going to have an antibody which is so specific and targeting just the T pallidum itself. So that's, we call it specific antibodies or Treponema antibodies, because the organism is Treponema pallidum. And so if you are producing antibodies against the Treponema, then become Treponema antibodies. Then you also have non-specific antibodies. Non-specific antibodies. The non-specific, so this becomes non-Treponema antibodies. But they will only be produced when you have been exposed to the treponemes. Yet these antibodies are not against the treponemes itself, but against other things. And those things are supposed to be like, you know, once you the body gets exposed to the treponemes, it has to respond, the host response. So there are certain things, certain tissues that the body also produces. Now, it is the body is now going to produce antibodies against the host tissue. So you see that it is not going to be specific for the treponemes. So that's why we say it is non-specific or non-treponema. To the extent that if you have malaria, all right, if you have malaria, these antibodies will show positive. If you have some other disease conditions which are not associated with the Treponema pallidum itself, it will show positive. So that is the second class of antibodies that are produced during syphilis infections. I hope that you are following the discussion. Now, this type of antibodies, which is non-specific, is called reagent, not reagent. Reagent, R-E-A-G-I-N, reagent. Some people want to believe that this antibody is not an antibody, because if it were an antibody, antibodies are specific. So if you have an antibody, in quote, which is targeting other things, then they cannot be an antibody. That's why they gave it this name, reagent. So if you like, you can call it reagent antibodies. So just to bring out the point that they are not true antibodies. If they were true antibodies, they will not be reacting with other things which did not stimulate their production. I hope that point is clear. Good. I want us to take this note very, very critically, because it is going to have an influence on our subsequent interpretation of our VDRL reportage. Now, Treponema antibodies, remember we said that when you have Treponema infection, or for that matter, syphilis, you are going to produce Treponema antibodies and non-Treponema antibodies. So two types of antibodies. The Treponema one is the first to show. Okay, the Treponema antibodies, which is the specific one, is the first to show. it is also going to persist throughout your lifetime. This is a very important information that must be kept in mind, that must be used when you want to interpret any VDRL reportage. They are saying that if you have syphilis, syphilis will produce two types of antibodies, specific and non-specific. The specific is the treponema one, which is targeted against the treponema itself. It will be the one to show presence in the bloodstream or in the serum. Once it has shown up, it is going to be with you throughout your lifetime. Right. What this means is that if you do a test that is going to be specific, then it means that you cannot use it to know whether somebody has a current infection or has an old infection. Because remember, we said that treponema antibodies will show first. And once they have shown presence in the blood, they are going to be there throughout your life. So if I've had an infection before, syphilis infection before, and I've been treated, after 2 years, after 3 years, if you go and do the test based on the specific antibodies, it will show positive. After 10 years, when I've been treated and I don't have a reinfection, and you test for syphilis, for me, using the treponema antibody phase, I'm going to be positive. And unfortunately, this is what is happening in our country. As we move along, you know why I'm making this statement. I'm saying that treponema antibodies will show first and to persist. What it means that for as long as you have had syphilitic attack before, and you have been treated for the next 10 years, 20 years, 30, for as long as you live, if you use the treponema antibodies test, the person will still going to show positive. So let's move on. So now the testing. So we have established a foundation that once the body has been exposed to the treponema pallidum, the body is going to produce antibodies. It's going to produce two types of antibodies, the treponema and the non-treponema. All right, so that is our background information. Now, what tests are we going to do? So if you are going to do a test, then you should be using antigens. Remember, because we are saying that the body has produced antibodies. So if the body has produced antibodies, then what material are you going to use to test for it? The material you're going to use to test for it should be an antigen. You can't use an antibody to test for antibody. You are going to use an antigens to test for the antibodies which the body has produced. All right. So you must use two types of antigens. One, which is specifically the treponema pallidum antigen, which will now pick up the treponema pallidum antibodies, the one which is specific to the T pallidum. And you can use another agent, which is non-specific. And this one, as we move along, we're going to use what we call cardiolipin. Cardiolipin is a cardiac muscle, and it's going to serve as an antigen. So you can have, and it's easy to get cardiolipin, not necessarily from the human being. It can be from, we have the porcine cardiolipin, that is from the pork. We have the beef cardiolipin from the, of course, from cattle. All right. So it is easy for manufacturers to prepare a lot of cardiolipin. This cardiolipin is serving as an antigen for the non-specific antibodies. Remember, you said the non-specific antibodies will attack other things other than the treponema. So if you have the treponema, it will attack it. But if you don't have the treponema itself, but other things to it, will also attack it. So that is why it's called non-treponema. And the antigen which we use there is cardiolipin, and not the T pallidum antigen itself. Where you use the T pallidum antigen itself, it means that you are going to now look for the specific antibodies. But if you want the non-specific antibodies, then you cannot also use the T palliative antigens. You have to use something else. And this something else is the cardiolipin, all right, which is the heart muscle, right? And this heart muscle cardiolipin, which was developed in a laboratory, and that laboratory has now been named after the disease, which we call the Venereal Disease Research Laboratory. So let's move on. Let's move on. Remember, let me read the second bullet for you. The most commonly used non-treponemal tests are Venereal Disease Research Laboratory, which is the VDRL, which is very common, all of us know, and a rapid plasma reagent test. Unfortunately, a lot of people don't know about this. But the reason here is that they said that the non-specific antibodies are called reagent. So if you are going to develop a test for the non-specific antibodies, then you are developing a test for the reagent, not the reagent. Now, if you look at the original Venereal Disease Research Laboratory, the procedure is very elaborate. All right. The procedure is very elaborate. In the reagent tests, which we'll talk about later on, it has been fast-tracked, so to speak. So it becomes a rapid. And with the Venereal Disease Research Laboratory test, the original one, you will necessarily need a serum. All right. With this one, with our bridge one, you can use plasma. And you know that using plasma and serum will also tell you that one becomes quicker. Because if you're going to use serum, of course, the sample will have to be collected, allowed to clot before you can separate to get your serum. But for the plasma, you take your sample, there's an anticoagulant, and then you can easily get your specimen. So all these things makes the second test very, very rapid. So that's why we call it rapid, and because you are using plasma, and because your target is to test for the non-specific antibodies, which we call reagent, you have it called rapid plasma reagent. So you see that the rapid plasma reagent is a modification of the Venereal Disease Research Laboratory test, the VDRL. So as we move along, I'll throw more light on that. Right. So, like I said earlier, the VDRL test is named after a laboratory that developed it. That's the Venereal Disease Research Laboratory. All right. Now it is microscopic and by flocculation. I'm sure you know the difference between flocculation and agglutination. In agglutination, there is antigen antibody binding. All right. And therefore, the aggregates are very compact. In flocculation, there's like there is a reaction between an antigen and antibody, which are not so specific. And for that matter, it's like a clamping of a sort. And therefore, it is just, you see some clamps which are not compact. All right. And with the VDRL, you have to microscope. It means that the flocculation has to be examined under the microscope. Again, it has to be heat inactivated and a serum. So with the VDRL, that's why I said that the VDRL is a long test. The VDRL, all of us know, or you should know, it's not what people are doing as VDRL. And I'll explain. The VDRL test is a flocculation test. If it's a flocculation test, then it means that there should be some antigen antibody reaction, which is even not too, which is not a true aggregate, some clamping of a sort, which should be examined under the microscope. But I'm sure all of us know that we are not doing that in our labs. So it cannot be a VDRL. Okay. Now it has to be heat inactivated. Heat inactivated, and it also has to be serum. So it means that if you want to do VDRL, you need a serum. You have the blood has to be collected and then allowed to clot. Now it has to be heat inactivated. Remember that we said that we are going to, the VDRL is non-specific. All right, if you remember, it's non-specific. If it's non-specific, it means that apart from the antibodies that we are even going to look for it, there are a lot of things that can react, a lot of things. And you know that if there are a lot of things that are going to react with it, then clotting factors and all of those things have the tendency to react with your antigen. So by preparing a serum, when you prepare a serum, you take off almost all the clotting factors. All the clotting factors will have been used up. And so that will reduce the possibility of reactants in the test that you're going to do. All right. And then you also know that there are a lot of other things too that can be that can still be present in your serum. So if you put it at 56 degrees for, let's say, 30 minutes or 1 hour, then all the other things in the serum will be inactivated. That's why we call heat inactivation of a serum. So all these things is just trying to reduce the false positivity in this test, because in the VDRL, you're saying that it's non-specific. The antibodies which have been produced are going to react with cardiolipin. Cardiolipin too can react with a lot of things. So the essence of the heat inactivation is to try to minimize as much as possible the things in the serum which can cross-react with the cardiolipin. I hope the point is clear. Right. And all these things makes the VDRL test complex. All right. And also make it like time wasting. You need a lot of time, and then at the end of the day, you have to prepare your test, or for that matter, your preparation has to be on a slide, because you are going to examine it on a microscope. Therefore, they should be on a glass slide. So that is the concept. And we're saying that the antigen which you are going to use is cardiolipin. And cardiolipin, lecithin, cholesterol, it is lipid based. Cardiolipin is lipid based. So the preparation becomes stabilized in what we call lecithin and cholesterol. All of us know about cholesterol. Lecithin too is there. So when the cardiolipin has been prepared in a lecithin cholesterol medium, then it can make it stable. So your reagent is cardiolipin, lecithin, cholesterol. But the actual antigen, which your antibody is going to react with, is the cardiolipin. There is a chart. Let me check here. This, what is the difference between TPHA and the, okay, right. So hold on, you will move there. What's the difference between TPHA test and VDR and RPR? Okay. So just understand the VDR for me. You move on, you understand the RPR2, and then from there you also move to the TPHA, and you understand. So by the time you move to the next 3-4 slides, I think I will have explained, or you have understood your own question. So I'm saying the VDRL is based on antigen called cardiolipin. This cardiolipin has capacity to react with reagenic antibodies. That those antibodies that have also be produced by virtue of syphilis inoculation or syphilis infection. Remember, you said that when you have syphilis, you produce 2 types of antibodies. One is specific, one is non-specific. We are talking about the non-specific one. The non-specific one will react, which is the antibodies will react with cardiolipin. And remember, cardiolipin too will react with other things, especially those things that are in the serum. To minimize this false reaction, the serum has to be used. When you use the serum, you are taking off all the clotting factors. So no clotting factor will react to the cardiolipin. Then the serum will also have to be inactivated. And I'm saying that once you put serum in at 56 degrees, I think this is also a known principle. Put serum at 56 degrees, heat it for 30 minutes, it will inactivate a lot of the factors that can also react with with your antigens. So you have heat inactivated the serum. All right. And remember, all these things will take a lot of time. Serum, to get your serum prepared itself will take about 30 minutes. Or the blood will have to clot, you spin and get. The inactivation will take another 30 minutes. So about 1 hour is gone. When you now take your heat inactivated serum and then your reagent, which is the cardiolipin, when you mix them, you have to mix them on a slide, because at the end of the day, you are going to examine the flocculation, which is like an aggregate, in a microscope, under a microscope. Therefore, the thing has to be done on a slide. So I'm saying that all these procedures will prolong the testing schedule. I hope now my point is clear. Your antigen is not, in the VDR, your antigen is not the tripallium. Your antigen is cardiolipin. Cardiolipin is a heart muscle. And manufacturers routinely will use porcine cardiolipin, which is the pork heart muscle, or the beef cardiolipin, which is the beef heart. All right. Now, so I'm sure you have understood the VDRL. This is the VDRL. And I'm sure you know that if this is the VDRL, then what we are doing in our labs is not and cannot be VDRL. That's one point that I want all of us to understand. Let's move on. Then the RPR.
The voice seems to be breaking,
now,
please. Is it general?
The RPR uses the same antigen as the VDRL. So it means that the antigen there will be cardiolipin. Is that not it? Cardiolipin, lecithin, and then a cholesterol. Because the RPR is the same antigen as the VDRL. So it's the same thing. Nothing has changed. However, carbon particles have been added so that the flocculation reaction can be seen more clearly. What it means here is that we say that our main target there is cardiolipin, that's heart muscles. Now they have attached carbon particles to them in the RPR. In the RPR, the original VDRL reagent now have been carbonated. So there's carbon absorbed to the, let me see okay. I hear this is breaking. I hope it works. Right. So the VDRL, I'm sure now you can understand the VDRL properly. That it is a flocculation test. It is microscopic. You need serum, and even the serum you need to heat inactivate it. It has to be put on a glass slide because you are going to examine it under a microscope. And we are going to look for flocculation, not aggregates. The difference between agglutination and flocculation. Okay. All right. All right. So here we have the same VDRL, the same everything about the VDRL. However, the reagent has been modified. The same reagent, now we are having carbon attached to the cardiolipin particles. Carbon has been added. So once carbon has been added, then it means that once they flocculate, the flocculum, all right, the aggregates, let me put it that, the aggregates, remember the original cardiolipin, you have to use them, even if they have aggregated, you have to use a microscope to look at the aggregates. All right. Now, once you have added carbon, then when there's aggregation, the carbon will now still come together. So the carbon will now enhance visibility. So it means that with the RPR, you don't need microscope. You see it? Because carbon particles have been added to the cardiolipin. So if the cardiolipins aggregate, then you are going to have all the carbon particles coming together and giving you a black sort of aggregates for you to see without a microscope. So it means that RPR, you don't need, what do you call it? you don't need a microscope, become macroscopic. So that actually is a very good modification. The RPR2 is going to use plasma instead of the serum. Okay, it's going to use plasma instead of serum. So it means that it also makes the test cheaper, time very shorter. All right, because you remember you said that in the original VDR you have to use serum. Here you're going to use the plasma. It makes it shorter. And so the element of rapidity comes in there. So rapid plasma reagent, we're saying that the reagent is talking about the fact that we are looking for antibodies in quotes that are not true antibodies. And that has been described as reagent because they are not specific. Any antibody which is non-specific loses its characteristics as an antibody, because one of the key characteristics of antibodies is about their specificity. They can only attack the antigens which stimulated their production. So if you now have a certain antibodies from the serum which is reacting with cardiolipin, then it means that it cannot be called an antibody, so to speak. So I'm sure that this explains very well the concept of RPR. So RPR, so the RPR assay can be performed on unheated serum or plasma, and it's read macroscopically. I hope the point 2 is clear. So now the VDRA test has currently been replaced by RPR tests in most clinical laboratories. So in most laboratories, it is RPR and not VDRA. All right. Now, however, VDRA assay can still be used to test for CSF for diagnosing neurosyphilis and newborn. You see, the concept here is that I'm trying to sway away a little bit just to throw light on what is happening in the country. Now, we are saying that we are not going to do the full-blown syphilis. If you have to do the full-blown syphilis, you have to go through the primary, secondary, latent, and then the tertiary. At the tertiary phase, the syphilis will now invade the CNS, the central nervous system, to create to cause what we call neurosyphilis. So if there's a suspicion for neurosyphilis, then what specimen will you need? You need CSF. Okay, you need CSF. If there's a suspicion for neurosyphilis, the organisms have moved away from the blood and now have entered into the CNS. So why are you looking for it from the blood? Okay, so it means that if there's anything, you have to take CSF. And you are also going to look for antibodies from the CSF. All right. Now, in the CSF, all of us know that production of antibodies in CSF is not as strong as you have it in the bloodstream. All the immune systems, you have them in the bloodstream, and so antibody production will be enhanced in the bloodstream. You can't have the same in the CSF. So if there are antibodies in the CSF, the level of antibodies in the CSF will be very, very low. Okay, will be very, very low. If the level of antibodies in the CSF will be low, then you realize that you need, if there are small aggregations, you use the RPR, you miss it. Because RPR is done, is examined macroscopically. Even if you say, okay, you are doing RPR, say you want to use the microscope, because of the carbon, the carbon is going to block, you know, you use the bright field microscope, and therefore light must pass through. Once you have used carbon, how is the light going to pass through? So if you use RPR, you cannot still use the microscope. So the RPR, it is unaided eye, the microscope, macroscopic. So if you want to use the CSF, if you use RPR for CSF, you can get it wrong, because the antibodies in CSF are very low. If the antibodies are low, then the aggregation will be very, very low that you can miss them in the RPR. So therefore, since the VDRL itself, original VDRL will be microscopically examined, then it means that it is better to use the original VDRL to test for CSF if there's a suspicion for neurosyphilis. In that case too, you will realize that in the original VDRL, you use serum. Meanwhile, this is CSF. You heat inactivate. You don't need the heat inactivation because the essence of the heat inactivation is to now try to scale down the number of things in the serum that can cause false positivity. All the things that can cause false positivity in the blood are not available in the CSF. So you see that when you are doing VDRL in with the CSF, you are not going to heat inactivate. There's no heat inactivation anywhere. You don't need that. And then, of course, you don't need serum after the CSF. So that is the principle. So as lab scientists, these are the kind of information that you have to know. If there's a strong suspicion for neurosyphilis, then you need the original VDRL. Even if you have RPR, you don't have to use the RPR because RPR will give you false negative, because the content, the titer, the level of antibodies in the CSF is usually very low. If they are very low, aggregations or flocculation will be very, very low. And once they are very low, you are likely to miss it in the RPR. And therefore, since our VDRL will require microscopy, then even the smallest amount is like when you do Coombs test. If you do Coombs test, I'm sure that if you want to report, your final reportage should be under the microscope, because in Coombs test, the aggregation may be so weak that if you want to use your naked eye, you will say it is negative. But if you examine it under the microscope, there could be small aggregates for you to report it as positive. So you see, so if you bring the scenario here, you see that when the aggregations are too small or too weak, without a microscope, you can say that it's negative. All right, but with a microscope, you see that positive. So that is why I brought this one here. And then also in newborn, you know that we screen mothers for syphilis. Why? Because syphilis can be vertically transmitted. You know vertical transmission? Vertical transmission, when you transmit an infection to a partner, it's called horizontal because you are all on the same level. Horizontal transmission. Vertical transmission is from one generation to another. If a mother transmits an infection to the unborn baby, placentally, I mean through the placenta, it means it is moving from a mother to a child, and that's from one generation to another generation. We call that one vertical transmission. So it is not every infection that can be vertically transmitted. If I have E. coli, if you have E. coli and you are a pregnant mother will not transmit E. coli to the, I mean, of course, that has not been reported. Of course, there are certain infections when you can transmit it to the unborn baby, and syphilis is one of it. That's why they screen mothers at the antenatal clinic. They screen mothers for syphilis, so that if the mother is shown to be positive, then they can take steps to prevent the transplacental infection. So if a mother transmits, an infected mother transmits it congenitally to the unborn baby, depending on the time, if the mother, if the transmission occurs very early, in, let's say, in the first trimester of a sort, by the time the baby is born, you could have deformed the baby to some extent, or even if they don't know, the baby is also beginning to produce antibodies. All of us know that the production of antibodies in the babies is so weak. All right. So you will see that if you have a newborn baby and the doctor is suspecting congenital syphilis, is suspecting that the mother may have this, you are going to take the child's or the newborn sample. Do you think RPR would be the best? RPR would like we said about the CSF, because the level of antibodies in the newborn will be so weak, if you do RPR, you are likely to miss it. It is rather proper to do VDRL, because VDRL will give you the benefit of the microscope, and therefore every small clamps can be seen. So if you have a well-established laboratories, you should have RPR, you should also have VDRL. But these days, nobody even has, some people even haven't seen the VDRL before. They haven't seen, they are using strips and they are reporting as VDRL. You move forward and you see where the problem is coming from. So I'm hoping that at this point, you will know the difference between RPR and VDRL. Now, most laboratories use RPR. That's fantastic. Now, it is still important to have VDRL or get VDRL also in stock, just in case there's investigation for neurosyphilis or congenital syphilis. And I've told you the reason why in neurosyphilis or congenital syphilis, the reason why you do the VDRL in all these cases, the level of antibodies are usually very, very low. In the neurosyphilis, you use CSF. CSF antibody levels are low. And therefore, if you use the RPR, which you are going to examine using your naked eye, the level of agglutination, for that matter, flocculation is so low that you are likely to miss it. VDRL will give you the benefit of the microscope, and for that matter, you can diagnose. The same thing will go for suspected congenital syphilis, where a newborn is suspected to have been born from a mother who was positive, but probably the mother was not tested for syphilis. Later on, after the mother delivered, where they saw that the mother was actually positive for syphilis. Meanwhile, at that time, at the antenatal level, the mother was not giving any protective prophylaxis, and therefore the child may have been exposed. In that case, there's a suspicion for congenital syphilis. If you do RPR, you are likely to say it is negative. I hope all these things I've explained very well. Right. Now let's go to the next point. And by the time you finish here, you know the difference between VDRL, RPR, and then the TPHA that was asked. So all the things that you talk about, VDRL, RPR, they are all tests for the non-treponema, and for that matter, non-specific. Okay. Right. So now you're going to confirmatory. So if something is non-specific, then it means that you can use it to confirm. Let's make this point clear before we move to this. Because we are not doing syphilis as a topic on its own, some of the information may miss, but I think this one, let me go back. Even though we said that VDRL is non-confirmatory, it's said, so to speak, it's a screening test. If you do VDRL on CSF and it's positive, it's considered as confirmatory. You can explain. I'm saying that VDRL by all standards is non-specific. If it's non-specific, then it means that it cannot be used as confirmatory test. We are saying that, however, if you use it on CSF for diagnosing neurosyphilis, if you use it, it is considered as confirmatory. Why? Who can explain? The person who can explain will get some bonus 10 marks before the exams.
Doug.
Another speak can put it on the platform, on the chat. I'm saying that VDRL, by all the discussions that have gone on, they are all non-specific, non-treponema, non-specific, and therefore non-confirmatory. However, if you use it on CSF in a suspected case of neurosyphilis, If you do VDR is positive, consider it as confirmatory. Why? Give myself some 2 minutes for an answer. If the answer comes, fine. If the answer doesn't come, I'll tell you. But if the answer comes, whoever gives you the correct answer, will
Can I
have
try?
some bonus 10 marks.
Can I try? Because in the CSF, the concentration of the antibodies are very low. So if it comes up positive, that means you see that it is giving us a positive when we do the VDR.
All right, I'm getting some answer there. CSF is sterile sample which has few antibodies. Cosby, I'm sorry, I won't take it. CSF is sterile sample which has few antibodies. No, that's not too correct. Yes, I'm looking for another answer. An answer that will attract 10 marks anyway. Okay, so you see that in the blood, and for that matter, serum, there are a lot of things that can give you false positives. Okay, let's get this answer. The concentration of CS is usually low, so the that's one. Thank you for coming in, but so let's take the answer. So in the blood, if the VDR is shows positive, remember I've told you that one of the reasons why the VDR is using serum and it's also using heat inactivation. Some answers. Okay, this is, let me check this answers. If you're an VDR is positive in the CSF indicates an active infection and the central nervous system. Okay, all right. So but okay. So all these answers will not give you the full marks. All right. So but thanks for trying. And it gives me the hope that you are actually following the discussions. Thank you so much. Right. So you see that we said that in the VDRL, you're using serum. And we said that one of the things is that you want to take off all the clotting factors because they have the potential of interacting with the cardiolipin. We said that we also do heat inactivation also to also take off a lot of the things, the cofactors and a whole lot of other things that can all also cause false positivity. Now, as far as CSF is concerned, all those things that are in blood that could give you false positivity are absent in the CSF. But I won't take the word sterile because when you're talking about sterility, you're talking about an infectious agent being there or not. All right. So it is not sterile as such, but all the complements, all the other things that are present in serum, which could give you false positivity, are all absent in the CSF. And for that matter, once CSF is showing positive for VDRL, then it could be nothing but antibodies for a reaction with the antibodies for the syphilis. So that is the answer. You don't have too many interference substances in the CSF that could give you false positives. So if CSF is showing, if VDRL is showing positive in CSF, it is considered confirmatory for syphilis. Thank you very much. All right. So now examples of confirmatory tests are the FTA. The FTA is the fluorescent troponemal antibodies absorbance test. And then we have the TPPA, which is troponemal pallidum particle agglutination test. And the one that you know very well, troponemal pallidum heme agglutination test, the TPHA. This is what you know very well. All of them are confirmatory. Okay, so it means that these ones, the antigens that are used are troponemal pallidum antigens. And once they are troponemal pallidum antigens, if they show positive, It means that they are picking the Treponema pallidum antibodies, not the non-antibodies. Not the non-Treponema antibodies. And so that's the specificity. All right. Now let's take note of the second point. I'm sure all over the country, everybody uses the strip. I think that's a point. Let me take it before we move on. Yeah, this is a good answer, but it came very late. They have less or no interference in the eighth nature. Yes, this is the correct answer. That's one, but it came so late, so probably you can't get the marks. But thank you. That's one. Thank you very much. That's the best answer. But it came in too late, and therefore your marks have been. Sorry, I can't give you that marks, but I've taken judicial notice. All right. So so all over the country, everybody using the strip, the VDRS strip, so-called VDRS strip. Take note of this. The rapid strip tests, they are based on immunochromatography. All right, immunogenic, and then chromatography means that they will give you a color. So you see that if there's a reaction, you see a color band. So that's immunochromatography. And these are all based on the enzyme immunoassays. And enzyme immunoassays are all specifics. So you see that the rapid strip test or the EIA, which is the enzyme immunoassay kits, are also Treponema tests and are therefore confirmatory tests. I hope that you are getting the point. So if they are confirmatory tests, are they VDRL? Definitely no. They are not VDRL. They can at best be said to be TPH because the doctors know about TPHA. They don't know about anything. If they know VDRL and they don't know RPR, the doctors don't know RPR, they know VDRL. And then they don't know immunochromatography, they know about the TPHA. So the doctor will write either VDRL or TPHA. Apart from this, they don't write anything else. But you and I will know that if the doctor has written VDRL, okay, now I have TPHA. Sorry, I have, let me take this interference in this. Okay, so this another one coming from down there on the CSF, and then the posterior. I think you have taken the answers that are coming out now are very, very correct, and I want to thank you for that. So we are moving on. You're saying that for the confirmatory tests, which is specific, they include FTA-ABs, which is the fluorescence Treponema antibody absorbance test, the Treponema pallidum particle agglutination test, and the almighty TPHA, which is Treponema pallidum heme agglutination test. These ones are the ones that you know. And even with this one, the doctors know about TPHA alone. And I'm saying that the doctors know about VDRL and they know about TPHA. They don't know about RPR. But you know that VDRL and RPR are the same. The RPR is an enhanced and rapid form of the VDRL. The exception, the exception is where there's a suspicion, you want to diagnose neurosyphilis. When you want to diagnose neurosyphilis, you don't go in for serum. You don't use serum to diagnose neurosyphilis. If there's neurosyphilis, suspicion for neurosyphilis, you go in for CSF and you do the VDRL. I think you have explained that. But for normal, ordinary syphilis, suspicion for syphilis, you do the VDRL. So you do the RPR. But the doctors will not write RPR. The doctors will write VDRL. So if you have RPR, you will do the RPR and report at VDRL. Or at best, you can report VDRL stroke RPR. So that as you move along, the doctors will know that, oh, VDRL is, as you move along, they will know that, oh, it's the same thing as the RPR. Or if they don't know, the person will come and ask you, what is this about? Then say, oh, VDRL, the modified form is the RPR. So we are doing this one. Then the explanation goes. So you can do that. Now, if your screening, and for that matter, your non-Treponema test or the non-confirmatory test is showing positive, then you go ahead and do the confirmation test. But what we are seeing here in Ghana across every laboratory is that everybody is using the strip to do the VDRL. I'm saying that that is wrong because the strip is based on immunochromatography and it is based on enzyme immunoassay techniques. And enzyme immunoassay techniques are all specifics. And so they are also treponemer tests. If they are treponemer tests, then you can use them if you are doing the TPHA. Just as if you are doing the VDRL, you can do RPR to in place of the VDRL. So if you are doing TPHA, you can still use the strip one in place of the TPHA. I hope the point is clear because they are all treponemer tests, they are all specifics. Now let's move on. Something will come up. The confirmatory tests, which are the TPHAs and then the strip one that we are all using as VDRL, they are confirmatory tests. They have better sensitivity and specificity. Remember, when it says sensitivity, it means that they pick small, any small, even if there is weak, you can pick it up. They can pick it up. And they're also specific, so that as opposed to the VDRL, it is non-specific. This one is specific. So if this one is say positive, it means that you know that you're dealing with syphilis. Now, let's take the next one. This test, I'm talking about this confirmatory test, however, cannot differentiate active from a previous infection. Who can explain? We said that if you go back to the previous discussion, we said that we have two types of antibodies that are produced in response to inoculation or infection with treponemes. You have the specific and non-specific, treponema and non-treponema. And then we made a point that the treponema antibodies will come out first. And when they come out first, they will stay throughout your lifetime. So if they will stay throughout your lifetime, it means that at any particular point that you do the test, it will show positive. And it will also mean that it will show positive for the confirmatory test, because the confirmatory tests are those that will check for the specific antibodies. So it means that if you use the strip as we are using now, it's going to be a confirmatory test. Confirmatory test will check for the treponema antibodies. The treponema antibodies, once they are produced, will be there for life. So it means that if the patient is positive by the strip, let me go and take all the medicines in this world. Come after next year or next month or 2 months, you show the strip to positive. Let me go and do everything. Go and see all the gauze, go and do all the withdrawal, go and do all the things. I become next 5 years to show positive. That is what we are doing in this country. And that is very, very dangerous. But let's move on. We'll come to something. Yes. Joshua, you are picking up very, very good. So the confirmatory test, the specific antibodies will show first and will persist throughout your life. And I'm saying that the strip test that we are doing is not VDRL. The strip test we are doing is also immunochromatography. It's based on immunochromatography. Immunochromatography is based on enzyme immunoassay techniques. And enzyme immunoassay techniques are nothing but specific. So once they are specific, it means that they are treponema, and therefore they are confirmatory. So you see how the narration goes. So if that's the situation, it means that if a doctor requests for VDRL and you do the strip test, you're only doing TPHA, because we said that the strip test is also a treponema test, and TPHA is also a treponema test. So if you do the strip test, it is as if you are doing the TPHA. So if you do the VD and the RPR and you do the VDR, you haven't done anything wrong. The same way, if a doctor requests for TPHA and you do the strip one, you haven't because they are using the same principle. Okay, so that is that. We are saying that the confirmatory test, one, they are very sensitive and specific. This one you know. but they cannot differentiate between active and non-inactive, because the active is the fresh infection. Okay, I mean the person has been exposed fresh, and like you said, if it's a primary syphilis, the first week or 2 weeks, if you do all these tests, you show negative, because at that time antibodies have not been produced. But from, let's say that the 4th week, 5th week of the same primary stage, we call it late primary, antibodies will have been produced, and those antibodies will be the specific ones. The specific ones will be picked up by the strip, because the strip is also specific. All right. So you see that if you are using the strip test, you cannot, and for that matter, TPHA, and for that matter, any of the confirmatory tests, you cannot differentiate between active infection and a past infection, because somebody who has been treated years ago, past infection, previous infection, it will still continue to show positive. I hope this point have been well noted. It's happening in our labs across the country. I wanted to do this topic, the syphilis, this thing at Congress last year. I think we had some challenge with timing and we couldn't do that. It's something that's happening across the country. Every laboratory in the country, I don't know how many laboratories use RPR or VDRL. Everybody's using the strip. The funny thing is that a doctor will request for VDRL, and then a lab A will use the strip. So you report positive. Then you say, go and do TPHA. And then you go to another lab B. The lab B person to know that, oh, the strip can still check for the T pallidum. And then you also use the strip to check for the TPHA. Then you also become under positive. What are you doing to yourselves? All right. So here, there's a point which we should take note. After this, I think you'll be covered. Right. Let me see. There's a note here. Let me see. No. The TPHA can be used. Please, can TPHA be used for therapy for measurement? No, we've said that TPHA, like all the confirmatory tests, cannot be used to monitor. Let me make my last point, then this thing can come out properly. So with the confirmatory tests, let's look at the last point. The confirmatory tests, which include the TPHA, which include the strip, they are therefore not suitable for screening. Okay, they are not suitable for screening, because if you use it for screening purposes, then anybody screening, you are looking for people who have been infected. And since you cannot differentiate between past and active infection, if you do screening, you are only going to cause confusion with the strip. So it means that the strip cannot be used for screening. One, cannot be used to monitor therapy, for that matter, for treatment. So your question, your point has been answered. You cannot use the TPHA and for that matter strip to monitor treatment, because you've said and said again and again that the strip is also treponema, and for that matter confirmatory, and for that matter specific. And for all those, for this test, they will pick the treponema antibodies. Treponema antibodies will be there whether you have treated or not treated. It means that you cannot use it to monitor whether the patient has infection or. As for the titers, it doesn't come in. The titers can be used in the area of the VDRL. Why? The VDRL, one, is non-specific, and it degrades with time. So I think, like I said earlier, this topic is not for syphilis per se. It was just for the peptic, so that's a peptic, penile ulcers. And we're dealing with the aspects where syphilis can contribute to that. And I try to veer off a little bit into this. So we are not doing syphilis as a whole topic. But I hope that you will now appreciate that the VDRL can be used to monitor treatment. Why? Because if you have an infection, like you said, the treponema 1 and the non-treponema 1. Non-treponema 1 will be picked up by the VDRL. The non-treponema 1, once the infection has been cleared or you have been treated, it will begin to come down. The levels, the titers will begin to come down. So what it means here is that since the titers of the levels of the non-specific antibodies will come down upon effective treatment, it means that you can do your titers. So what it means is that the person has been tested positive for VDRL, and then you want to do your titer. You do your titer, you get, let's say, 1 in 256. Okay, and then you have been given treatment, and then let's say it comes in about 1 month. You do a titer, it can come to 1 in, let's say, let me say 1 in 32. So if it comes to 1 in 32, you see that yes, the person, the treatment has been good. And the next time it comes in, you can come to 1 in 4. The next time it comes in, you do the test and it's negative. All right. So it means that you can rather use the VDRL, and for that matter, the non-specific one, to monitor treatment, because the non-specific ones, after effective treatment, the antibody titers will come down, will be coming down. So once it is coming down, it means that you can use that to monitor your treatment. However, with the specific one, I mean, the level that come in will stay in for life, and therefore it will not go up or come down. So it means that you can use it for treatment. So TPHA, and for that matter, the strip cannot be used for monitoring treatment. However, VDRL, if you have it, and for that matter, RPR, if you have it, can be used to monitor treatment, because the non-specific antibodies after treatment will degrade. The levels will come down until, let's say, after 6 months, then it will come to 0. So what it means is that after treatment, you can be monitoring the titers. You see the titers coming down, until finally it gets to 0. All right. Now, the question. All right. So, yeah. So for screening purposes, you should do VDRL, and like I've said, VDRL is virtually not available. But you can do there's I'm going to show you this one. There's something we call reverse algorithm for syphilis. I don't have note on this, but take note. There's what we call reverse algorithm for syphilis. What is an algorithm? Algorithm is the procedure in doing things, the step-by-step procedure in doing things. Is that right? That's the algorithm. So the algorithm for diagnosing syphilis will have been first and foremost to do your screening one. The screening one will be your RPR or VDRL. So if you do your VDRL and it is positive, then okay. So if you do your, I'm saying that I'm going to explain what we call reverse algorithm for syphilis. And what is it? To know the reverse algorithm, you should first and foremost know what is algorithm. Algorithm is a step-by-step. You want me to get to the note, then it means that we are doing syphilis. I've said that our major lesson is penile ulcers. And one of the penile ulcers is caused by syphilis in the primary stage. So primary stage syphilis will give you an ulcer. So that's why it falls under penile ulcer disease. Now, if you want to do syphilis, you do syphilis primary stage, secondary stage, tertiary stage, and then before you can say Jack, all our days are gone. So I'm just giving you the important note. The important note, which you can easily understand. I'm saying that to understand reverse algorithm, you must understand what is algorithm. Algorithm is a step-by-step procedure in doing things. So the algorithm for diagnosing syphilis will have been, first and foremost, to do your screening test. And what is your screening test? Your screening test will be your RPR, which we say it's actually replacing the VDRL. So first and foremost, you do your screening. Screening is done by your RPR, all right, because it is non-specific. You said that you can use the specific test to do screening. Please take note. You can only use the non-specific one to do your screening. But if you do the non-specific one and you do your screening, which is the RPR, it is positive, you don't end there because screening is screening. Then you have to do the confirmatory. So from there, you go and do the confirmatory, which is the TPHA, or for that matter, the immunochromatography, which is the strip one. So that will be the normal algorithm. The normal algorithm is that do your screening first or the non-specific test first. Once the non-specific is positive, go ahead and do the confirmatory. That's the normal algorithm. Is that all right? Normal algorithm. Okay. What is reverse algorithm? Reverse algorithm is the other way around. So what it also means is that it is also not wrong to use the strip as a screening. Please take note of this. Otherwise, you go back and then you say, oh, if because I don't have the VDR or RPR, if a doctor brings the request for VDR, I won't do it. You'll do it. That's why I'm bringing this concept of what we call reverse algorithm. Reverse algorithm concept is saying that you can still go ahead and use the confirmatory test, and for that matter, your strip as your first line. Remember, under normal circumstance, for normal algorithm, you use the confirmatory as your second line, because first and foremost, you should use the screening as your first line. If you screen and it is positive, then you move to the second line, which is the confirmatory. I hope that point is very, very clear. Nobody has any qualms about it. Good. Reverse algorithm is saying that you can still use the your second listen, your confirmatory test, and for that matter, your triponema test, and for that matter, your strip test. You can still use it as your first line. Now, if you use it and it is negative, assume that your VDR is negative. This one, you can go and read anywhere. I'm saying go and read about reverse algorithm for syphilis. And I'm giving you the snapshots. Reverse algorithm principle is saying that it is okay, it is acceptable to use the strip, which is in actual fact triponema test as your first line. If you use it as your first line, it is negative. Consider your VDRL as negative and report as such. But if you use it and it is positive, okay, don't report on it. Go back and do your VDR, and for that matter, your RPL. I hope the point is clear. Good. Reverse algorithm is saying that it is okay to use your triponema test, your confirmatory test, your rapid strip test as your first line. It is normal. So if you have your strip, don't go and trade them away. It is normal to use them. And for as long as the strip shows negative, report VDRL negative. No problem. You haven't done anything wrong. However, if your strip shows positive, remember your strip is a confirmatory test. Confirmatory test picks the triponema test, triponema antibodies. Triponema antibodies will be there throughout your lifetime. So if the person is positive, it doesn't conclude that the person has active infection. That's where now it says that if your strip test is positive, go back. And that's the principle of reverse. Because you should have done the VDRFS and then come to do the strip. Now you have done the strip test. If the strip is positive, go back and do your RPR. So whenever you go back and do your RPR and it is negative, then what does it mean? You did your strip test, it is positive. Then you want to apply your reverse algorithm principle. You do your strip, it is positive. You go back and do your RPI, it is negative. What does it mean? Yes, an answer for 5 marks.
Hello, Grandpa. It means it's not active. It has been treated and it has been treated, so it's not active.
It means the patient doesn't have an active infection, but what does he have?
Passive.
So you have tried, but the answer is like, yes, this is a past infection. That's Clifford for you. Clifford, that one. So I owe you 5 marks. So it's a past infection, as simple as that. If the patient doesn't have an active infection, yes, but it doesn't have an active infection, but what does he have? He has a past infection. So I give it to Clifford. Clifford, that one. Your answer is more correct. So, because if you don't do this, then once you have said a positive, the doctor will still be giving antibiotics to the patient. The patient will go back, 3 months, will come back, will come and do the test to still show positive. And therefore, it will be, it's like you'll be receiving treatment throughout life. So I'm saying that there's what we call reverse algorithm for syphilis. The normal algorithm is that do your screening test first. If your screening is positive, you go and do your confirmation. Okay, that's the normal algorithm. The reverse algorithm allows you to use your strip, which is also a treponema test, as your first line. If your user strip it is negative, report VDRL, even though you know yourself now, at least for this, by this lecture, you know that the strip test is not VDRL. And I'm saying that by the principle of reverse algorithm, if you use it as negative, you can report it as VDRL negative. However, if you use it and then it is positive, wait and go back and do it. If you don't have RPR, find another laboratory that has RPR. Let the patient go and do it there. Or you yourself can take a sample there, and then for best practices, it's good to collaborate with laboratories. All right. I've done my strip test, it's positive. Do you have RPR in your lab? Yes, I have a sample here. Can you test it for me? If the test for the RPR is negative, don't, because as soon as you report positive for the video, the patient is going to be exposed to another course of treatment. And this is what is happening throughout the country. I'm telling you, throughout the country. Of course, I set my laboratory because I insisted that we use. So we have at Confonati, I can tell you with all confidence, we have the RPR there. So, but you don't use the RPR as our first line because the RPR is more expensive. The strip one is cheap and then fast too. Okay, so nobody is saying that by all means use the RPR as your first line. So you're using the RPR as a backup and use it using the principle of the reverse algorithm, which allows you to use the strip, which is the treponema, which is specific. Use it because it's cheap, it is simple, it is everything. But as soon as it gives you a positive result, wait and go back, and that is what we call the reverse. Go back and do that. But if you use it as negative, don't go back. If you use the strip as negative, don't go back. Report as VDRL non-reactive. However, if you use the strip as positive, please don't report positive. Wait till you have a laboratory that can confirm for you, or at best, no, please don't report it, because most of the cases that we are dealing with are all past infections. The people who use the strip and then positive, the patient will go, they give some jabs, and oh, please. So that brings us to the end of our discussion for today. The RPR and VDR test case in the market. Yes, RPR, alpha VDR, I don't know. Because somebody is asking whether they are available on the market. As for VDR, I don't know. The RPR, I know. RPR is very much available on the market. I said that we are the users. Nobody with the how do I call it? The suppliers. They don't deal with items that don't move fast. So because people are not buying the RPR, I'm sure they are not motivated to. But if you begin to purchase them, I'm sure you always get them on the market. I know for sure Confanachi uses the RPR. There's this story about 2 years back. A certain laboratory reported that Confanachi has issued syphilis positive blood for a certain patient. If those of you may remember, it was a big news. It was a big issue in the news. That you see, Confanachi uses this same principle. Because, for example, if you have had a past infection with syphilis, can you donate or cannot donate? You can donate. You are not infectious. If you were treated, and but if you are treated, and after some years, you are not more infectious. So that's the principle. And you see, so they do the strip test, and all positive cases, they do the what do you call it, the RPR. And if RPR shows negative, it is a past infection, and the patient is not infectious. And I'm sure that it is safe to issue such blood. So that's the principle. All right. Now, somebody came for blood to another hospital, and then the hospital to which was good, they also tried to screen the sample. So the person did the strip test, then it showed positive. So by all professional ethical standards, I'm sure you're a lab scientist. You've done something like this. I think the best thing to have been to contact Confanachi. Call, make any means, even if you don't have contact with Confanachi, any means possible, call back to the lab and say, oh, this is a situation, blood has been submitted to my facility here for this, and this is what I found. Was it a mistake or something? Then you could have explained. Then, before you could say Jack, this gentleman who's supposed to be a lab person gave this, oh, then you can imagine a patient who apparently claimed that they are going to buy blood and then being told that the blood syphilis. How will you take? And before you could, within the next 5 minutes, the whole thing is in the news that Confanachi has issued this. So when you go to this is a pure technical ignorance, scientific ignorance. All right. Because if you use the strip, anybody who has had past infection will always show positive. And I'm sure that this discussion is to enlighten you to know that the strip test is based on immunochromatography, and it's enzyme immunoassay principle, and it's specific. And once it's specific, it becomes confirmatory. And all confirmatory tests for syphilis will test for the treponema antibodies. Treponema antibodies, once they have been elicited by any infection, they will be there and be positive for life. This thing is very, very important. As scientists, we should know. So if you use the TPHA or whatever, they will always show positive for anybody who has ever had an infection. But if the person is has been treated, the only way to show whether the treatment was good was to do the VDR, or for that matter, RPR, because the RPR, those antibodies will scale, will degrade with time. And so with time, you see that at best, even if the VDR, the RPR will show positive, you see that it will show you positive. And then the next time you repeat the test, you show that it becomes negative. Or if you didn't know, you can take your initial titer. You can do the titer, and I'm sure you know how to do titers. Titer, let's say you record a titer 1 in 128. The next time you came to us positive, you want to do the titer. You do the titer, it becomes 1 in 4. It means that you can still use that one, even though the patient is still positive. But you can use the differentials in the titers to say that this is the patient is responding to treatment. Because his initial titer was 158, now it has come to 104. The patient doesn't need to go to another treatment. The only thing is to advise the patient to come, let's say in a month's time, to come and repeat the test. If you repeat the test, it should show negative. The patient should be cleared. All right. Thank you so much for your time. I thought that we were going to close at 8. It's almost 9. Thank you. Thank you. You continue, God willing, tomorrow. We are going to do Shankwes, which is the other ulcer on the penis. If you have time, you do chancroid and then hepatic ulcers. Right. If you don't, I don't want us to push too many things at the same time. So we will see. If it's okay, we do just a chancroid, and then if you have to get more time, we will add another one. But otherwise, we are done for syphilitic ulcers. Thank you so much. Please, any question? Anybody with a question for me? All right. Good night.
Hello, sir. Hello, sir.